Okay, so we're gonna talk about care plans today. And we start with care plans, we have to have a nursing diagnosis, which is our NANDA diagnosis. So we can't just pull it out of thin air. It has to start a certain way, it has to have a related to, and it has to have an as evidenced by. Then we're gonna have a goal. The goal has to match the nursing diagnosis. 5 interventions with rationales, and the rationale is just the why you're doing it. And it's not something that you just pull out of thin air just because you think it. You have to look at it in the book and find it. If you're planning on going to RN school, they make you put a notation at the end of it as to which book you used and what's your page number or your internet source. So it just can't be because you breathe better when you set up. You just can't make up something out of thin air. Then we're gonna do the evaluation of the goal. So let's talk about our patient. Let's say we've had a patient that has came in with congestive heart failure. And we know this because they've got crackles in their lungs and they've got a chest x-ray that says they've got congestive heart failure. And their O2 saturations, when we check it, is like 88%. And our O2 saturations, ideally, we want to be over 93%. So he had a fall at home, maybe he has not had a bowel movement in a few days, but what's his number one problem? His airway. He's not getting enough oxygen. So to put that in it, now we just can't put patient doesn't have enough oxygen. We can't put congestive heart failure because that's a medical diagnosis. We have to put a NANDA approved one. And the one that comes to my mind is impaired gas exchange. And that's a NANDA approved diagnosis. Now that just isn't the end of it. I mean, that's your NANDA part, impaired gas exchange, related to, we just cannot put congestive heart failure, because again, that's a medical diagnosis. You cannot put a medical diagnosis in the related to. We would have to kind of explain what the physiological process of, so they've got related to. So why are they having an impaired gas exchange? So they have fluid accumulation in bilateral lower lobes. So that's why their gas is being exchanged, is having an issue. That they have got fluid built up in their lungs because their heart is not functioning properly. And then you have to do an as evidenced by, AEB. And that just means as evidenced by what? How do we know this? How do we know that that is what's going on? So, and as evidenced by their gas exchange, we could put O2 sat of 88%. And we could even put a diagnosis of CHF, because we could put a medical diagnosis there. And we can put chest x-ray, or we could put chest x-ray with congestive heart failure. So that says, this is the problem, this is what's going on, and this is how we know it. Okay? So now we've got to have a goal. What would a goal be? And y'all can join in my video. What's a measurable goal that we want for the patient? A goal is what the patient is going to do. The rationales is what the nurse is going to do. Number one, the goal always starts with patient will. Always starts with that, patient will. So what is a goal for our impaired gas exchange? What should it be? Can y'all think of anything? It will get easier. Go ahead, Jennifer, you know it, say it.
I don't remember the name of the
Patient will have O2 sats above 90 or something.
Exactly. We want it to be normal though. Like we don't want to say patient to have an O2 sat of 89, that's still low, or even 90 is considered low. So we want it to be normal, so greater than or equal to 93% on, and DOC means day of care. Because on my goals that I want you to do, I want to know what your goal is for today. I go in at 7 o'clock in the morning, my goal by the time I leave at 7 o'clock at night is what here? What do I want to happen? The book will have goals written out in 30 days. In 2 weeks, this patient's gonna be somewhere else in 30 days. So write your goals for what you're gonna do that day. Because if your goal ultimately is I don't wanna kill them. I don't wanna kill them, I don't wanna make them worse, we wanna make them better. So patient will have an O2 saturation of 93% on the day of care. Now that book will have all kinds of fancy things that you can do, but don't overthink it. What are you gonna do this day to make their O2 saturations better? The first thing, I'll give you a hint, if our goal says that they're gonna have an O2 sat, and that's our goal, what's one of our interventions got to be? No?
Had a bed raise?
No, and it's all good, but what do we gotta have, one of our interventions, we gotta check it. We gotta check the O2 sat. So we're gonna check O2 sats. Now, most interventions have to have a frequency. You just can't put check O2 saturations. How often are you gonna check it? Oh, we're working at PCU today. We're doing it every 2 hours. We got good nursing. Q2 hours, that's good. So we're gonna check O2 saturation every 2 hours, and then you have to have a rationale out here. We're not gonna write rationales. You have to find you a rationale as to why you would do that. So what else are we gonna do today that's gonna make them breathe better? Y'all
Raise the head of the bed.
Oxygen. O2 per MD order. We can do that. Now there's a lot more than 5. For any care plan, you gotta have 5 interventions. Again, if you plan on getting your RN, you will have to have as many interventions as possible, sometimes up to 20 or 30 with rationales. Yeah, it's painful. Okay, so we're gonna check their O2 sats. We're gonna give them oxygen. Somebody said
Had a bed. Had a bed raise.
head of bed. We're gonna do head of bed, to elevate, head of bed.
Could you maybe do like deep breathing or something?
Deep breathing, or what they tell you to do every 2 hours.
Turn.
Turn, cough, and deep breathe, Q2. TC and DB, that's what that means in nursing. Turn, cough, and deep breathe, Q2 hours. Again, you've got your rationales, you've got your rationales, you've got your rationales. Not a rat, we don't want a rat up there, but that's rationales. What else we're gonna do to make sure our O2 sats are better?
Maybe like some kind of like movement, like.
Incentive spirometer, look at you. Incentive spirometer, usually Q1 hour. That's the little machine that's at the bedside, and you have to suck in on it, and it elevates this little ball. It forces your lungs to expand.
That's what I was trying to, the exercise.
If the exercise those. Anything else?
When you're writing care plans, you can leave spaces, correct?
Yeah.
Okay.
So what else could we do? We've got to check their O2 sats. We're going to give them oxygen. We're going to elevate the head of the bed. We're going to turn, cough, and deep breathe. We're going to do incentive spirometry. What about
Get them up to the wall.
ambulate them, increase activity? Ambulate. How about this? If you got a patient with congestive heart failure or breathing problems, do they breathe better when the room is hot or cold?
Cold.
Cold.
Yeah.
Keep the room cool. What about that tripod position? Elevate the head of the bed, put them up in the tripod position, like on their bedside table like this. It helps their lungs to expand out. And we could even do, with congestive heart failure, the doctor's gonna have them on a diuretic to try to pull that fluid off of them. So we could do diuretic per MD order. You could even do nebulizer treatments, where you put the medicine in the nebulizer and you breathe it in, it helps to open it up. So everything that we've done is aimed at this goal. You could even do that you're listening to their lung sounds every 4 hours. There's nothing wrong with that. But, so look, we've got 10. We only needed 5, we got 10. So we've done all of this. At the end of the day, we're gonna go in and the evaluation always starts with either goal met or not met. Was your goal met or not met? Nikki, at the end of the day, what was your patient's O2 saturation?
95.
It was 95. So goal met. And then it's kinda like Miss America, you only got to repeat the goal. You don't have to say, goal met, the oxygen, I checked the O2 sat every 2 hours, I gave them oxygen. You don't have to rehash all of this. You just redo the goal. So goal met. Patients, O2 sat is 95% on day of care. Now, what if it was still 88% at the end of the day?
Go not met.
Goal not met, patient's O2 sat was 88% on the day of care. And there's nothing wrong, when you walk into the room on your patient and you look at them for the first time, like our patients of our, the pictures that we watched, you should be thinking, what's my goal for this patient for the day? If whenever you go to clinicals and you wait till the night before to sit down and write your care plans, you're jinxing yourself. When you go in and meet your patient in the first 10 or 15 minutes, you should run back and sit down somewhere and say, okay, this is my goal for the day. This is what the three main problems are. So, if your goal isn't met, that's not a bad thing. A lot of goals you set for the day are not gonna be met. If they're not met, it's goal not met, then that just means you got to, okay, I've done all of this, but what else do I need to do? Maybe they need to ask the doctor for a chest x-ray. Maybe they need to change their nebulizer treatments. Maybe the patient's getting too much pain medication and they can't take a big enough breath. That just means you regroup, okay, I did all of this, that's fantastic. Let's do something else. We're gonna do another one. If anybody wants to snap a picture of this, you need to snap it real fast. Isabella's gonna take a picture and gonna post it on Facebook.
Yes.
You want me to stop the video?
No,
Oh.
keep rolling.
Okay.
This is hot. We're you know, oh, we're about to edit that thing out. Okay, now, let's do an at-risk. Usually when you go to clinicals, well, you have to do 3 care plans. 2 of them need to be actual problems, but 1 of them can be an at-risk. What are most people at risk for?
Skin integrity. Oh,
Balls.
yeah, that too.
Infection, constipation, skin breakdown, there's so much. But if a patient already has a break in their skin, then they're not at risk anymore, they've got an actual problem. So let's do at risk for falls. So we'll do risk for falls related to, like, okay, why are they at risk for falls? Maybe they had, maybe they've got weakness, maybe they've got new onset of confusion. Impaired mobility is technically a NANDA part.
Stroke patient.
If that's as evidenced by.
Early onset of dementia.
Risk of falls, dementia is a medical
Medical
diagnosis.
diagnosis.
Let's do this, let's make it simple.
Weakness on right side.
History of falls. Falls related to a history of falls. But see, we had so many already listed, maybe a new onset of confusion, maybe, weakness on the left side as evidenced by diagnosis of CVA, you could do that. So history of falls. So if an elderly person has fallen, that increases their rate by like 80% that they're gonna fall again. I'm not holding my mark right. Related to a history of falls. As evidenced by, we'll do they've had 5 falls in 30 days. Oh, that's a nursing home nightmare right there.
Mm-hmm.
So our patient will, what's our goal for the patient? Patient will
Not from.
not fall. That's your goal any day when you walk into a patient. Patient will not fall on day of care. Historically speaking, it happens 2 minutes right before you go to lunch or you leave for the day.
did you say patient will be stable on their, like, I don't remember the word right, but
See,
on
stable
their
is
feet.
vague.
Be
Our goal is, don't fall. Risk for falls. If it was impaired mobility, then maybe you could do, patient will, ambulate 20 feet with assistance.
Okay.
I mean, you see what I mean? It's gotta be a little weird. Now, what are we gonna do to be sure our patient doesn't fall today?
Round on your patient every 2 hours. Every hour.
Now, they have fallen 5 times. Is 2 hours gonna cut it with this one?
No.
Maybe 30 minutes. Yeah.
We'll do an hour. We'll try an hour.
Ambulate with assistance. Make sure you're walking with them. The gate belt.
Use gate belt.
Toilet every hour.
People historically fall because they gotta go to the toilet or you've pushed their bedside table way too far from their personal items are out of reach. So we're gonna toilet. We'll say 2 hours.
Educate,
Rugs.
educate, use a collar.
Again, that's only, you can use educate if your person's educatable. If you've got a new person with new onset of confusion, right, and educate them about a call light is pointless. Would you agree with that?
Mhm.
Give them a call light.
If you do, maybe you need a different type of alarm, depending on your patient. Some people can do a clip alarm, some people gotta have a TV monitor alarm, some people gotta have a pressure alarm. Some people can dismantle the alarms before you get in there.
Get fall mat. Make sure the bed's lowered and railed up.
Bed low position. What about proper lighting? What kind of shoes you want on?
That's good.
Maybe
Look at
they
there.
get them up out of their bed instead of just making them lay there all day.
What else did we say? Keep their bedside, keep personal items in reach. I don't like alarms, but, so I'm not gonna put alarms, but, it's hard to put them, some places consider an alarm a restraint, but some people you can put an alarm on and that's great, but they make a loud noise and usually an alarm just kinda tells you, hey, I'm already in the floor. A lot of times when you put alarms on people, if you hear an alarm, does your brain tell you to run or sit down? Run, it's not, lessons learned the hard way. We would put alarms on a lot of old military men and we'd find them under their bed. Because they were in the military and they would duck and try to get away. They would have some flashbacks. We did have one that you could record a voice to, and his lady friend had recorded her voice and said, Wilf, sit down. And after about a week, he was like, I'm tired of hearing her. He was so mad at her, we had to get rid of her voice because it had just really ticked him off. What about having a physical therapy assessment? Maybe to see if he needs some strength training. What about change position slowly? Do we teach people with their vital signs to change position slowly, not to jump up and rise too fast? See, look at all this common sense stuff that you do every day, that the book will make it seem harder than what it really is, that we've done. And we do a lot of this all subconsciously. We've got them, we're gonna check on them, we're gonna use our gate belt, we're gonna toilet them. We got the bed low, we got proper lighting on, we've got proper footwear on them, we've got their items in reach. We're gonna see if physical therapy can evaluate them, and we're gonna change positions with them slowly. That's common sense stuff that we do. So, with a rationale, you gotta have your rationale there next to it. Evaluation, is our goal met?
He failed.
He failed. He failed right when you was getting
We
ready
had
to
about
leave.
20 other patients. He failed.
Goal not met. If a patient falls, right then you go do a huddle. Usually in the nursing home, we used to pull together and do a huddle meeting. What happened? You kind of got to look at the crime scene. Who in here watches Law and Order and always wanted to be a crime scene investigator? Well, welcome to fall risk. If you want to make your job seem really fancy and, you know, you want to have that Law and Order dun 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 feeling, you go stand and say, okay, why'd they fall? Was the floor wet? Had they peed before they got up? Did they spill the water? Did they not have their shoes on right? Were there skid-proof? You know, skid-proof socks used to just have skids on the bottom. Now they're all the way around it. Why? Because people put them on opposite. Maybe they need a room closer to the nurse's station. Maybe they need a body alarm. Maybe they need a sitter. Maybe they need mats at the bedside. Maybe they need a bar to help them to stand up. It just depends on your patient. So when your goal's not met, you just gotta regroup. Maybe their blood pressure bottomed out. Maybe when you check their vital signs, when they stand, their blood pressure bottoms out. So maybe they need the doctor to review all their medications. Maybe they fell, and I'll tell you, I had a sentinel event one time where a nurse had gave a patient a sleeping pill, like an Ativan or something to help them rest at night, then went in and gave them a big dose of Lasix, a diuretic. You gotta pee, and then they were confused from the sleeping pill, and they got up and fell and whopped their head. That's something as nursing, you got to say, okay, I've already given them this, but I'm not gonna really give them this, and if I do give them this, then I really need to up my checking on them to be sure they don't fall. So does that sound too bad? Let's do one more.
Now, on the first one, where, on the interventions and rationale, like,
What do we do with the rationale?
You have to look in, you have to look in the book and say, why would I do this? If you look on the brown pages where the skills are in that fundamentals book, the words in italics are your rationales.
okay.
And have y'all figured out yet that you really should read those skills? Well, you're fixing to, because you're getting more into the skilly chapters. That's where a lot of the stuff comes from, is to the order in which you do things. Okay, let's do one more. Let's say that our patient has, give me a scenario, what do you think? Let's say they haven't had a bowel movement. Let's do that. Nope, y'all gotta do one of those for a drop box. Oh, y'all are gonna be sneaky Pete's. Let's do something else. Let's do a cute thing. Did y'all know that y'all had to do care plans before the drop box? So. Let's say our congestive heart failure patient here had to go have open heart surgery. Maybe he had a valve problem, so he has acute pain related to surgical incision, midline chest. That'd make you hurt. As evidenced by, he is status post in nursing, a CABG, CABG it's an open heart surgery. It's a bypass and graft. So he had a CABG, status post, 2 days. CABG, when you hear doctors or nurses talk about cabbages, oh, they had a cabbage. That don't mean they ate cabbage, that mean they had open heart surgery. Where they do a coronary artery bypass and graft, is what that means. Okay, so what's our goal gonna be? So, and complaints of pain, 8 out of 10.
Pain-free day of care.
Patient will be what?
Pain-free day.
Pain-free. Let me ask you this. So the goal has got to be measurable, and it's got to be reasonable. Do you think being pain-free 2 days after having your chest split is reasonable?
No, having
Would you
less
need to
than
do
pain.
Would you need to give it like a number, like,
We're gonna give it a number.
yeah.
She said like a 5 out of 10. It wasn't 8, so we want it better. Patient will we'll say less than or equal to 5. on day of care. Now, for example, like we could put here, maybe they had pain because they were constipated. Our goal could not be patient will have a bowel movement on day of care, because that goal goes to an impaired, elimination care plan. So you see how the goal matches the problem, right? And our interventions have to match this. Like maybe they haven't had a bowel movement in 4 days. I don't wanna put here check for fecal impaction, because that has nothing to do with this. Does that make sense? Listening to lung sounds is a great thing. But it doesn't really have much to do with that. Okay, so it says here they're gonna have a pain level of less than 5, so what is one of our interventions got to be? It says pain, exactly, how often?
Every
2 hours. So we've assessed their pain, then what else can we do for their pain?
pain management.
Pain meds per?
Doctor order.
After you give pain medicines, what do you need to do?
Check.
How do you know if it worked?
Check the pain level.
Check it again, reassess the pain. We'll say, what, about 30 minutes? See, the rationale for that would be to check the effectiveness. Because maybe that pain medicine you're giving them, it may not help, maybe they need something else. Or maybe it's just not holding them long enough. So we've checked their pain, what else could we do? Now, think out of the box, think instead of just slapping somebody in there, before you go in and give somebody a big shot of Demerol, what do you wanna try first?
Ibuprofen.
Something that's
What
not
goes straight to the
medicine.
pills, what else can you do besides just giving someone medicine?
Like heat or
Just because somebody's hurting doesn't mean that they need something, maybe they could just reposition.
Heater,
Reposition.
cold, derby.
PRN. It'd be great if every time we had a little cramp in our leg that we got a big dose of Demerol, but sometimes you just gotta do range of motion on it. Me too. What else can we do? So we've repositioned them,
Like, say you have like a chest, you can splint the tongue when they cough.
boom, teach them to splint. Okay, let's say that you've had even a chest surgery or a C-section, or how many of you ever coughed so much that whenever you cough, your whole body hurts? Teaching someone to hold and splint, teaching him to splint his incision with a pillow when he coughs. Just to hold. If you've ever had it, where's my C-section people?
Right here.
You hold that belly, or you think your uterus is gonna shoot across the room. I had strep throat after my last one, and I thought I was gonna die. On splinting area. Cause even when you turn in the bed, if you can just, cause if you don't splint, then all your meat just kinda jiggles, and that hurts. So if you kinda splint and hold everything tight, what else could you do? What about a calm, you're gonna think, your calm room. Maybe you need some distraction. If it's acute pain, usually someone could benefit from doing, you need the gait theory of pain. You need like massage. Of course, you can't massage their chest, but you can maybe scratch their back, massage their feet, massage their hands. Put on some, the music that they like. Let them play a video game or use distracting conversation.
Could you also use like aroma diffuser?
A what?
An aroma diffuser?
Probably, I'm gonna tell you, probably not with a cardiac patient, because their lungs are probably shot too, and they're not gonna want to breathe in any oils. But you could, maybe a scented lotion or something that's relaxing to them. So you could do some non-medical things, non-medication related items. Sometimes just quieting the room down, or even giving them a bath and scratching their back goes a long way.
Maybe like opening the blinds, get some sunlight,
Yep.
that might help feel better.
You can, for sure. Getting their mind off of it. Acute pain can be easily distracted if you can open the gate or close the gate to the pain, so, either by scratching their back, massaging, setting them up, using distracted conversation. Watching TV, talking about sports, whatever they're into. Talking to their grandkids. Sometimes you said you have no pain tolerance. Sometimes that doesn't help. But it does take your mind off of it. I mean, if you think about it, if you can get your mind off of it, it does somewhat help.
Maybe they make you laugh, cause it's gonna hurt him.
Yeah, you can't make nobody jiggle. So was our goal met or not met?
Yes.
Yes.
What was our pain level?
4.
2.
She took pain away all.
We'll do less than 5 on death care. That's our goal. But you see how it's got to be feasible? Like you said here that, somebody said it'd be pain-free. That's not realistic on 2 days.
Right.
They're gonna serve. Let's say if our goal was impaired mobility due to weakness as secondary to this cabbage, surgery they just had done, the next day for them to ambulate, how much do you think how much would your goal be to ambulate somebody a day after having open heart surgery?
2 times.
Maybe just up to the bedside chair 3 times a day. And you're not gonna expect to ambulate somebody 500 feet down the hallway and back a day after having that. So your goal has to be reasonable, it has to be measurable, and you can't use words like stable. They've got to be very, more specific, okay? Oh, yeah, take a picture of that.
That's like 2,
I don't know,
less than 5.
less than 5.
On.
Well, I was trying to think where I had 2.
I can't say that part.
Okay. So now you can turn it off.